You're looking at a multi-kinase inhibitor, a little new approach to patients with acute myeloid leukemia. Can you tell me what was the big issue here? What were you trying to investigate?
Well, we know that about 30% of patients with AML have a mutation in a gene called FLT3. And most of those patients who have a mutation, that confers a poor prognosis. They have a high relapse rate and a poor overall survival. So it was an unmet need, and we were looking to improve their lot, as it were. And since they have an activating mutation of this enzyme called FLT3, we wanted to inhibit the activity of this enzyme along with chemotherapy, hoping that this would affect a better outcome than with chemotherapy alone.
So you use a TKI, but why does it have to be a multi-kinase inhibitor?
It does not have to be a multi-kinase inhibitor. In fact, it was originally thought of as a FLT3 inhibitor. That's why it was used in this subtype. But we know factually that it inhibits more enzymes than just FLT3. So factually it is a multi-kinase inhibitor, but it was used in just FLT3 mutant patients because of its activity in that particular enzyme.
Tell me about the study. What did you do?
So we took a large number of AML patients who were between age 18 and 60, and we screened them to see if they would have this mutation. And we actually screened 3,300 patients and came up with about 714 that we could randomize based on the fact that they did have a mutation in the FLT3 enzyme to either midostaurin or placebo, in addition to standard chemotherapy.
And what happened?
The patients who received the midostaurin, as opposed to those who received the placebo plus the chemotherapy, did better in terms of overall survival and event-free survival. So it was indeed a positive study.
What were the numbers, in fact?
The hazard ratio in favor of midostaurin was 0.77, which means that there was a 23% less likelihood of dying if you had been randomized to the midostaurin arm as opposed to the placebo arm.
And you had big numbers, so this is a very meaningful result, it would seem.
Yes, I think so. I mean, it actually shows a result that did not happen by chance, as best we can tell by the statistics. It's a meaningful improvement in the outcome with a significantly lower risk of dying. So it could become the standard of care to treat this patient subpopulation.
Is there a downside from using midostaurin?
Well, there may be, but at least in terms of side effects, there were no excessive side effects except for a slight increase of severe rashes in those who were randomized to midostaurin as opposed to placebo. There were no increased deaths in the midostaurin arm, so at least from a side effect profile, there was no real downside.
How big an impact do you think this could have on therapy for AML?
Well, again, we have to note, at least for the moment, that the impact is going to be limited to those with this subtype of AML. And it's important to point out that to go on the trial, you had the patient's AML cells had to be rapidly assessed for the presence of the mutation. And this was done at one of 9 academic labs throughout the world. The patient would walk in the door with leukemia, their blood or marrow would get sent to one of these 9 labs, depending on where the country that this was taking place. And then the answer about whether there was a mutation or not would come back in 48 hours, and then the patient could go on the trial. So again, to emphasize the fact that you need rapid diagnosis of the mutation, in addition to standard diagnosis of AML, and then you get chemotherapy plus midostaurin.
Has this sort of opened the doors towards more molecular tinkering with acute myeloid leukemia?
I really think it has. Number one, it shows that the trial is feasible. I think that's one of the most important findings as well, that you can actually tell somebody's molecular subtype at diagnosis before you even give them a drop of significant chemotherapy, and you can base therapy upon that. So AML is a very heterogeneous disease, which means that one patient's AML is not like another's, and we have to take advantage of that heterogeneity intelligently.
Now, FLT3 is fairly common. Is this just the low-hanging fruit? Would other things be harder to win?
It's probably the lowest hanging fruit. It's one of the 2 most common mutations, but it's certainly of the 2 most common ones, that would be FLT3 and NPM1. It's the most druggable one because the mutation gives an increased function of the enzyme, and it's easier to inhibit an enzyme that's overactive than fix one that's underactive.
How do you think this might impact therapy in the near future then?
Well, the drug company that has the rights to midostaurin, Novartis, will likely submit this for approval in this disease and one other relatively rare disease called systemic mastocytosis, where it also works pretty well. They'll submit it for approval to the FDA, and if it gets approved, I think it may become the standard of care for this subtype of AML patients.
What should doctors take home from this right now then, do you think?
Well, they should take home, number one, that it is possible to target a molecular lesion along with standard chemotherapy, and that targeting, at least in this case, was beneficial for patient survival. And number two, they should stay closely tuned to FDA approvals to see when they can give this to their patients. Although Novartis will probably have a compassionate use program to make it available to patients before the actual approval.